I will call them, are our government payers, and we'll talk about some fairly new programming that they've had in place, all coming out of the Affordable Care Act. And they have said, through the Affordable Care Act, Congress has said to CMS that they need to produce a value-based purchasing program for all Medicare providers. So they started with hospitals. They're now focused on physicians and physician practices. They'll be getting into home health and hospice, long-term acute hospitals, skilled nursing facilities. So any of the providers that are paid by Medicare dollars eventually will get into this similar kind of program. We're going to touch on that tonight. But I first wanted to talk about a little bit in terms of what is quality, because quality is one of those words that sometimes people say, well, I don't know exactly what it is, but I know I want to see it, right? And so I want to talk a little bit about that from different perspectives, from the perspective of the patient. What does that look like? What about from the doctors or from the public? And then lastly, from our payers. What are each of these constituencies expecting when they want to see quality, safe patient care in a hospital? And that really is something that we kind of think about. Then go into accountability and leadership, including the governing body. I'll talk about sort of a three-legged stool of leadership and what it means to be accountable for that. And then finally, the real role, if you will, of the governing body itself, and then what you need to do to go into the future as you plan for the hospital. Any questions, just kind of stop me along the way, and we'll go from there. But again, starting with quality of care, what is that? One of the things that we've been doing in hospitals for quite a long time, I've been a nurse for 30 plus years, and I have been working in quality improvement and risk management and regulatory compliance. So those are the lions and tigers and bears, if you will, of healthcare for 20 plus years. And we in the hospital have been measuring different kind of metrics, collecting all kind of data to kind of showcase what we do in terms of providing high quality care to the patients that we serve. But what does that really mean? If you think about it from the eyes of the patient, it may be as simple as they're treating me very well. They're responding to my needs quickly. When I need a pain medication, they're bringing me that pain medication pretty quickly. My room seems to be clean, and I'm happy with that. Those are the kind of things perhaps that a patient thinks about. From the eyes of the doctors, it may be as simple as, can I really trust the people? Do I have confidence in the nurses at the bedside and the others that are there in the hospital 24 hours a day, 7 days a week, taking care of my patients? Are my orders being carried out appropriately? You know, is the patient being cared for? What is the quality of the diagnostic study that I get from the lab work or the x-rays? From the nurses and other of the hospital staffs, same kind of thing. You know, do I have confidence in my peers? Do I have confidence in the doctors who are taking care of the patients here? And can I put my trust in what they're asking me to do? Do I have enough people to help me? Can I get my work done in an 8-hour shift or a 12-hour shift and really give the care that I'd like to, you know, to a patient? From the eyes of the public, a lot of times it's what do we hear in the media, whether it be on the news report on television, what we're reading in the newspaper, now what we're seeing on the internet. You know, now consumers, the public, can go out to a government website called Hospital Compare. If you haven't been out there, you need to go out there, Hospital Compare. You can search on a city or a town, pick a hospital. You can actually pick 3 hospitals, so you can go out there, probably find ET&C Crockett, pick 2 more that are close to you, and then compare some quality metrics over time. So anyone from the public can go out today and look at that. What you need to know about that is the data that they put out there is older data, probably 18 months, 2 years, sometimes greater than 2 years. So you kind of have to understand that the information I'm seeing is old, but it's still there, and that's what your constituency, again, your public, is going out to see. From the payers, before we get into value-based purchasing, payers have always just paid a claim for payment for services rendered by the doctor, by the hospital, by any of the healthcare providers. But if I'm Blue Cross Blue Shield and I have a claim for a patient who has a pneumonia diagnosis, but all of a sudden I'm seeing charges that are related to surgery to fix a hip fracture, then I kind of what might have happened. Probably a patient with pneumonia who had a fall while they were in the hospital, who ended up with a hip fracture, and now that claim is coming to me as the payer to pay for that. They see those kind of things. CMS has said, we're no longer going to simply pay claims for Medicare and Medicaid patients. We want to see value for the money that we're spending. And that's kind of where, we see things going. So those are the different perspectives. How do you build a quality assessment performance improvement program? That term, we call it QAPI for short, came from CMS. That was the term that they used to define their quality program. If you think about a pyramid, it really should be based first and foremost on patient safety. Are we providing safe care to the patient? Is the environment in which we are providing care, so the hospital building, is it a safe place to get care, the patient population? Is it a safe place to give care, being our physicians, our staff, and even the visitors coming in? So the environment of care, very important. Physical plant, life safety, fire safety, all those things figure into the quality of care that's provided. The best practices out there are data-driven programs that are led by physicians. So I'm going to talk in a minute a little more about the fact that the ultimate responsibility for management and oversight of quality of care and patient safety rests with the governing body, right? We'll talk a little bit more about that. Typically, in many hospitals that have really robust, good quality programs, the governing body then delegates to the medical staff and to the hospital manager, to the senior leaders, to provide the oversight and management, and then you hold them accountable for that. So again, best practice, physician-led program that is data-driven. Now, in looking at the medical staff bylaws, I see that one of the standing committees of the medical staff is a quality improvement committee. My guess is that will be a physician-led program, and that quality improvement committee will do many things. Not only just what we would consider peer review for the physicians taking care of patients, but also quality improvement across the hospital. So you need to bring what's happening in the hospital and what's happening on the medical staff together. And if you have a committee of the medical staff that's overseeing that, then I think you're going to have a really good program. Now, I'll talk about structure of the board in a step, but there is a way that you can kind of connect the dots between the governing body and the hospital. So, regulatory compliance, accreditation, regulatory compliance. From my perspective, from a clinical quality perspective, accreditation standards, the Joint Commission, there are other accrediting organizations out there, certification by CMS. So every hospital has to be certified to participate in the Medicare and Medicaid programs. Meaning they have standards, they call them the conditions of participation, or the COPs for short. So CMS expects that every hospital getting federal funds will be in compliance with the COPs. So when you have an accrediting organization like Joint Commission, Center for Improving Healthcare Quality, CIHQ, another one of the accrediting organizations, their standards have to also match and mirror the conditions of participation. There are many hospitals across the country, especially small hospitals, and in our critical access hospital population, that don't use an accrediting organization, primarily because of expense. They simply are CMS certified, meaning that they have state surveyors from the Texas Department of State Health Services, is the state survey agency for Texas, and so there would be a survey team coming out from the department to survey the hospitals to make sure that they're in compliance with the COPs. It's free. There's no real expense to that. If you choose to be accredited, again, by Joint Commission, by CIHQ, or one of the accrediting organizations, that organization has gone through an approval process with CMS to become what they call a deeming authority, meaning that if my hospital is accredited by the Joint Commission, then I am deemed to be in compliance with the conditions of participation for Medicare. So as you think about, where you want the hospital to be, consider the regulatory atmosphere relative to being CMS certified or accredited by one of the accrediting organizations. And certainly there are really pros and cons to both of those choices. Okay, any questions so far? Let's talk a bit about moving from volume to value. So that's kind of, you know, our foundation in healthcare is shifting, right? So we're not just fee for service any longer. They're going to be looking for that value occasion, which is cost and quality, right? So beginning on page 3 in that slide there at the top, there are actually 3 programs now that CMS has that will impact the reimbursement that you get for Medicare patients. So right now I'm only speaking about Medicare patients. Medicaid is beginning to look at that from a state level, but let's just focus on Medicare patients. The first one and the first one to be implemented is what's called the value-based purchasing program. So that started in, fiscal year 13. And when I say fiscal year 13, that's the federal year, which begins in October of every year and then goes through September. They started looking at certain measures. Kind of across the bottom of that slide, you can see that you're going to have measures, and from your hospital's performance on those measures, you're going to be giving, it's rated by a point system. They go into a certain domain. I'll talk quickly about what those domains of care are, and then they weight them according to what they think is the most important. You finally get a total score. That total score is going to help figure what your payment adjustment for Medicare claims will be. Okay? Stay with me. So the domains of care are things like clinical process. So we hospitals have been reporting on heart attack, pneumonia, heart failure care for quite a long time. Those are the kind of measures that they're looking at in process. They look at patient experience of care through our patient satisfaction, our patient engagement surveys. That's a part of it. They're now looking at outcomes of care. So they're looking at mortality rates for certain patient populations within the hospitals. They're looking at infection rates, hospital-acquired or healthcare-associated infections, things like our central lines, Foley catheters, urinary tract infections through Foley catheters, surgical site infections, those kind of things. And so all of those things come together to give you a performance score. Either you have met the threshold of the mean across the country, or you're improving over time just based on comparison to your hospital. Okay, so you're going to get the total score for value-based purchasing. Down at the bottom there, you see rated readmission. So the readmission reduction program, the second of the pay-for-performance programs from CMS. They're looking at readmission rates, patient readmission rates, again, for heart attack, heart failure, and pneumonia. This year, they're adding chronic lung disease, COPD, chronic lung patients, and hip and knee replacements, so joint replacements. So they're looking to see if I came in with a primary diagnosis of pneumonia, I went through my episode of care, I went home, was I readmitted back to the hospital within 30 days of that discharge? Now, it may be readmitted back to this hospital where I got my care, or maybe I went back to another hospital. But nevertheless, the Medicare program is going to know that because they're going to have the claims that are specific to me. So they're looking at those rates, and hospitals that are determined to have excessive readmission rates for those patient populations are going to be penalized. So value-based purchasing, you can actually get a bonus, or you can get a penalty. Really good performers can get a bonus. Really bad performers are going to get a penalty. Readmission reduction is a penalty-based program. Okay? The third and the last of them, just starting October 1 of 2014, is called the Hospital Acquired Condition Reduction Program. So these are things like pressure ulcers, bed sores, and a number of different primarily post-surgical complications that happen with patients. It goes back to our central line infection is a part of that. Falls with trauma. So if I fell and I had a fracture while I was in the hospital, those are the kind of things that fall into this particular type of program. Once the data is collected, again, this information all comes from the claims that come to Medicare. Once the information is collected for a year, they're going to rank the hospitals, and those that are in the 25% lowest performing hospital, or those 25% with the highest rates, again, establish a penalty for that. Okay? So down at the bottom, here's where quality and finance come together. It shows you that for value-based purchasing programs, one of the things Congress says was, we want to put this in place, but it has to be budget neutral, right? Has to be budget neutral. So what did Medicare decide to do? They decided to withhold payment by a certain amount each year from the hospital. So they're going to withhold payment from every claim that comes across, and that hospital now has the ability to earn back that money. You can earn back all of it. You can earn back more than they withheld. That would be the bonus. Or you might not earn back any of it. That would be the penalty. So if you look at that slide for right now, today, and then on into 16 and 17, you see the withholding there, kind of small, but they started out at 1% in 13, and then they have added a 0.5% as they've gone across. So right now, in federal fiscal year 15, which is where we are today, they're at 1.5%. So every time the business office gets a Medicare claim that comes across, or Medicare reimbursement for a claim they processed, 1.5% is at risk for being taken away. Okay? Depending on what your value-based purchasing score is and your readmission rate is, they're going to put a payment adjustment figure on that. Again, it may give you more than that 1.5%, or it may give you some proportion of that. Some cases, hospitals it'll be a wash. They withheld 1.5%, I'm getting 1.5% back, so basically it's a wash there. Readmissions penalty, you can see that they started at 1% in 13, and then as of October 1 of 14, they went up to 3%, and they'll stay at 3% for the foreseeable future. So now we have 1.5 being withheld, 3%, 1.5% of each DRG payment that the hospital gets, right? Are there hospitals that have established now with readmissions you can get the full 3% penalty, or you may get somewhat less than that, dependent on the excessive readmissions. Do we have hospitals across the country that were getting the full 3% penalty? We sure do. They're there. So right now you've got 4.5% at risk of your DRG payment. Then if you fall into that 25% lowest performing hospitals with hospital-acquired conditions, that's another 1%. So they figure your payment adjustment for value-based purchasing readmissions first, and that gives you a payment. And then if you're in that 25% of lowest performing hospitals, now they're going to take an additional 1% off of that. So again, over to the right, you can see that we're up to 5.5% for the fiscal year that we're currently in. As of October 1 of this year, if you put at risk up to 5.75%, and then in federal fiscal year 17 going forward, the hospital stands to lose 6% of each DRG payment that comes across. When I talk to hospital leadership groups, and my friends and CFOs are in the audience, that's when the light goes on, and they're like, wow, we need to really know and understand more about what this is. Part of this, the claims-based measures, are based on coding, how we code out our claims to send them forward for payment, which is based on physician documentation. Okay? And so finance and quality need to be working with our medical staff to help everyone understand how this is all going to play out and how integrated they are. So quickly, accountability of leadership, CMS, the Joint Commission, CIHQ, all of the accrediting regulatory compliant departments see leadership. When they use the term leaders or leadership, again, it's that three-legged stool, and that's what you've got there. It's the hospital leadership, the executive management staff, medical staff leadership, and the governing body. They want to see that those areas are integrated and talking to each other about quality and patient safety. They especially want to know that the medical staff and the governing body, even outside of hospital management, but the medical staff and the governing body are paying attention and talking to each other about the quality of care and patient safety within the hospital. So, the role of the governing body, again, is that you have ultimate responsibility for management and oversight of the quality program. Oftentimes, again, you'll delegate that to the medical staff and hospital management, which is the appropriate thing to do. But how do you hold us accountable? That's going to come through the way in which you see reports, the data and the information, the transparency with which the hospital brings you forward the information that you need to make decisions as a governing body. If CMS comes in and they do a survey of the hospital and there's some fairly significant findings that are deficient, they're going to come back to the governing body and want to know what's going on. You've got oversight of the quality program. How are you holding accountable the hospital management team and medical staff to provide safe, quality care, right? So, oversight structure, the first important thing, again, as I said, in your medical staff bylaws, I see that you've got a quality improvement committee, there's a standing committee of medical staff. That's a great wonderful thing. In many hospitals nowadays, there is some subcommittee of the governing body that looks specifically at quality of care. What you're going to find is that your board meetings are so packed full, the agenda, that you simply don't have the time, oftentimes, to kind of drill down into the data and information and understand what you're seeing. Some hospitals, small hospitals, have chosen to offer up a board member or two board members who actually sit on the existing committee, as opposed to having a subcommittee of the board that has to meet at some other time. So there are a number of ways that you can really get that job done. There should, though, be, every time you meet, some kind of quality report coming back to you with data and information from hospital management primarily. It may be that there would be a report from medical staff and they enter into that, but most of that information is going to come back from folks like me who have aggregated the data, collected all the data, really looked at it and analyzed it, try to identify for you where the opportunities for improvement are, and then to talk to you about what we're doing. So, holding us accountable for that is what you can do. The little thing I've got there, Einstein never stop questioning. Community members of governing body bring new eyes and new perspective to the information that we see every day. We get so close to it sometimes we can't see the forest for the trees. But when you've got community members on the board, you can look at certain things and ask those hard questions. You know, if we're just not getting the discharge instructions to the heart failure patients, which is one of those things we've been measuring on for a long time. You know, I have seen it before where it's compelling to have a board member saying, I don't understand it. Why can't we get this right? You know, what is it, what's the challenge? What's the barrier there? And those are the kind of questions sometimes that board members should and will ask. So, your role, developing strategic goals. From my perspective, planning for quality is no less strategic than planning for growth or managing finances. They all now really go together. In fact, I would say in your strategic planning session, think about what your quality agenda is going to be, and that should then help drive some of your budget decisions, right? All those other things, establish priorities. You're expected by the Medicare program to work with hospital management to establish the priorities, to set goals and expectations, and then to hold us accountable, again, by data reports and that information that comes back to you. So one of the things probably in the future, as you do a board self-evaluation, I always encourage you to think about a needs assessment of your board members relative to, again, further education and training around the quality program. And what is it that you need to know? You know, you first of all need to know what kind of information is going to come to you, what kind of data we're going to be giving to you, and then sometimes to help with understanding what that data means. And I think that's probably right now where you are, is beginning to look at that, put the right structure in place, and then we're going to come back with transparency and other questions that you have in terms of how to hold us accountable. So a lot of words. Any questions that you have?
Yes, ma'am. I guess I quite understand the readmissions penalty. I mean, what's the rationale for driving that?
Okay. Well, again, I can speak from a Medicare perspective. You know, in the hospital, you know, back in the day and for forevermore, we've always looked at readmissions as one more way to fill beds, right, Bill? When we were looking at volumes, you know, we've got patients that are popping back into the hospital. We're always looking to make sure that if I'm discharged with pneumonia and I pop back as another admission within, let's say, 20 days or so, you're always wanting to make sure that I wasn't discharged prematurely, right? That I really was stable enough and ready to go home. And now CMS is looking at it from a patient perspective. You know, is it the right thing for the patient to get home and then have to come back into the hospital? Or can we, the hospital, and our physicians in the community, and other providers in the community do a better job to make sure that our patients are going home when they need to, that they've got community resources that can help them support the management plan that they and the doctor have laid out? Do they have the resources, for instance, to get the medications that they need? Those are the kind of things. So they're really pushing the hospitals by this program to really assess where discharge planning is, what do we know about when that patient's scheduled to come back to the doctor, how can we facilitate and make sure that happens. Those are the kind of things. So they're also looking at it from a cost perspective, right? Because if I come in once, they're going to pay a DRG payment. If I come back in within 30 days, they're going to look at it. They've always looked at it to say, oh, are we going to give you another payment, or are we just going to tack that on to the one that you just had? So it's part quality, it's part cost. That's that value equation. They've chosen heart attack, heart failure, pneumonia, because those are the three patient populations that we have been looking at, we the hospital have been looking at and measuring for many, many years. And those are the three that they're focused on first. That's kind of their rationale behind it. What they do is they calculate what's called an observed over expected. So in your patient population for your hospital, there's going to be expected readmissions that happen. And then they're going to see how many actual that you have. That determines the ratio. And then from that, they determine is that excess or not. A lot of it, again, will go back to medical staff documentation. Now, if I'm having a staged surgical procedure, and then there's a plan for me to come back to have that second procedure, that's not counted in the equation. Makes sense?
Since we're starting from scratch, when does our record start?
Exactly.
Since you're starting from scratch.
We have no data. June 1st, we just
Right,
zero.
right. Well, that's a good question. And that's going to come probably from some work that we've got to do to make to help the Medicare program understand where one stopped and where one picked up. Now, it all comes on a quarter-by-quarter basis. So we'll have to do some work to determine. But new startup hospitals, I mean, they just start from ground zero. Small hospitals, let me just say, the small hospitals, especially in the value-based purchasing program, if you're not meeting certain numbers, if you don't have enough cases because you have a very small patient population, a very small average daily census, you may not meet the threshold to be participating in the program. And if that's the case, then the withhold doesn't happen, right? You still, so in all the measures that they have, you have to have at least 4 of those measures where you have at least 10 cases in that time period in order to qualify for that score. So there may be some domains you qualify for, there may be some domains you do not, just because of the hospital being so small. But where it starts as of June 1, yeah, that's what we're going to have to talk about. And it may come into, there are third-party vendors that we send our information to, and they send it on up to CMS. And so as this transition happens, we will move away from the vendor that has been doing this, and we'll move into a new vendor. So that will be one place where they can kind of show where the beginning of the new hospital was. So where you stand today, as a hospital today, I can't answer because I haven't seen the data. Now, you certainly tonight can go out to Hospital Compare, look up your city and look up the hospital just to see where you are. So, yes, ma'am.
Are the standards and the regulations across the board, or is there any adjustment of criteria or scoring based on the demographics of your population vis-a-vis, well, it seems to me that if you have a high Medicare population over 80, they're sicker than a Medicare population 65 to 69 or whatever.
Yes.
So is there any adjustment of the data?
Yes.
Being less stringent or more stringent? Or
They have what they call a risk adjustment methodology. So they look at things like demographics and gender and age and what we call comorbidities, or, so if I have pneumonia, but I'm also diabetic and I have hypertension and all those other. So they do have a way. Is it perfect? No. But it's kind of what they have. There are a number of different kind of risk adjustment methodologies out there. Amy's opinion on it. I think there are some that are probably more scientific and more evidence-based than others, but CMS does have a way of looking at that, and so yes, they tell you that the comparisons they're making are apples to apples comparison based on the risk adjustment. Other questions? Thank you.
That was a great presentation. Thank you very much. You don't have any comments? Okay, the next item on the agenda is the CHC management agreement. The lawyers have still not finished their work on that. I know this because they emailed it to me. So that'll have to be taken under consideration at next week's meeting. Last item on the agenda is public comments. Do we have anybody with an urgent need to say something to us?
Does it have to be urgent?
Sir?
You said urgently need to say, one comment? I want to just compliment
Okay.
the board and the folks that put it on the discussion last night. Lovely. I think you made great strides forward to get the people in the communities involved. Excuse me. I heard, I guess my comments are going to be short. I heard from the community very positive response after listening to the picture that was drawn by Bill, unfortunately. And basically the response was, okay, we've come through a lot of history that's behind us. We're looking forward. We want to help you. We want to help you. And I thought about ways to leverage that. I said, okay, get people involved if they really want to help you. Not many people want to help by showing up at meetings and participating. But I do think that if they were able to access information on a current time basis and understand what the load that you all have taken on, it was described last night in what I thought was kind of a shocker. You made this move on a leap of faith. Whoa. These kinds of moves are made every day. Businesses bought, tweaked, and move forward. But in those processes, usually there's a lot of due diligence. Scrub the numbers. There's a plan and a model that's put together that says, this is where we're going to be. And finally, it's full disclosure. And that's kind of what I'm talking about tonight. People have to understand what it is you're doing on our behalf. 2 suggestions. Have you thought about involving people in the public? We've got some good banks, we've got some good business people, to come in on and work with the board subcommittees in the area of planning and those kinds of things? That's the question. The second one is, because I think it would be beneficial if you did, leverage, bring in as many people as you can to get as much advice as you can. I wouldn't do your job for yourself. If you were $500,000 a year or something.
A little more than that.
No, I you're doing a big job that is undervalued in the community. I hear criticisms, I hear comments. I had a football coach one time said they never go above, and really they expect you to do better. So I'm saying that getting people involved will eliminate some. The second suggestion, and I'll shut up and sit down, was that all other agencies in the county, that their name starts with county, are on the website in the county, except Houston County Hospital. And my suggestion would be is to put a site on the county website, Houston County, that is information-based. Your planning process as it moves forward. I think it was a good description last night. It sounds like you're trying to unscramble an egg in real time as the train's moving. It just, they didn't understand it. But at some point, the process has to start where people understand, yeah, this is what it is. You're taking over a business. It was about, as I understand the numbers, $75 million last year. That's a big hit. It was an underperforming business. We had about a 27% occupancy rate in 49 beds. There's a lot of questions about how you turn that thing around. I think this information would help. Thank you.
Thank you, Roger. Okay, there being no more comments, we are going to go into executive session. I strongly do not anticipate any decisions. We will come back here and adjourn. But waiting around for us to vote on something would probably not be proper. But you're welcome to if you like. So, this part of the meeting is in recess, and we're going to move to executive session.